Good morning from all around the world and welcome to Structural Heart Life Cases, broadcasting directly from the Cardiac Catheterization Laboratory at the Mount Sinai Fuster Heart Hospital in New York City. My name is Pedro Moreno. I'm a professor of medicine and interventional cardiologist, and I will be your moderator today. We'd love to hear from you, so please send out all your questions through YouTube or through the website. And remember, all our previous cases from Structural Heart Life Cases are available for your review at ccclifecases.org. We have a great case for you, so let me transfer you directly to the cath lab for the in vivo case.
Thank you, Pedro Moreno. Good morning, everybody. I'm starting the case till Dr. Sharma joins us. So you see myself, then we have Gilbert Tang, Parasuram, who is our attending, and then we have two of our fellows, who is Penta and Taka. So let's go through the slides. So you see that, and echo.
Stam.
Yeah, Stam Lyracus. Exactly. And cardiac anesthesia was Spencer Daisy Laurent, who's just behind us. So the case today will be a discussion about the sizing. It's an interesting case in the sense we could go both ways, where we could use both Evolut versus SAPIEN. Even in the SAPIEN, there is a question about the sizing. So that is why I think we are having this case, most of it more of a discussion about the case. So if you see here, this is a case of a 84-year-old male who had presented with shortness of breath with significant 3-vessel CAD, and all 3 vessels had a recent PCI, atrial fibrillation, and history of cancer also. So significant aortic stenosis with normal EF. We can show the echo shortly, and he has been on a good therapy both for CAD well. So we'll show you. The TE was done outside, which are shown as shown here, was normal EF with a significant gradient across the aortic valve, which was a mean of 43. So this is what the CT scan showed. You have the echo?
Yes.
Yeah, let's
okay, let us show the echo
first.
before we go to the CT. Yes.
Thank you, Dr. Kini. Good morning. As you can see here, normal LV function. The aortic valve leaflets are thickened, calcified, decreased excursion of the leaflets. The patient has about moderate aortic regurgitation together with the aortic stenosis, mild MR, mild tricuspid regurgitation, no pulmonary hypertension, short axis of the aortic valve, as you can see, decreased opening of the valve with thickened calcified leaflets. Again, with color, turbulent flow, minimal PI, normal LV function, normal RV function, mild MR. As you can see, very thickened leaflets, not opening of the leaflets at all, calcified, moderate valvular AI. Pressure heart time 374, consistent with moderate. As you can see here, very high gradient, peak velocity through the aortic valve of 4.5, mean gradient of 50 that we got today by Dr. And as you can see here, the aortic valve area 0.9 centimeter square, severe aortic stenosis with moderate AI, mild MR, 3-chamber view, and no pericardial effusion. Thank you. Normal RV function too. Thank you.
Okay, let's go back to the slides. Okay, Gilbert.
Yeah, so this is, a case that we commonly see in a clinic. I think that's why we present today. We're not showing an esoteric case. You can see the annulus is, the mean diameter is on 24. You can see the area is 453 and perimeter is 77. LVOT is a bit smaller, tapers down to around 379, perimeter 72, and the mean diameter is on 22, 23. Next slide. So keep those numbers in mind. So STJ is very big, sinuses are very big, so no issue of coronary obstruction. Left main height is high, so the root is big. So it's not an issue about the anatomy. You can see some calcification in proximal ascending aorta. Tri-leaflet, you saw it from Stam's echo. Very calcified valve, and confirmed that on the CT scan as well. And interestingly, this is a mixed severe AS and moderate AR case, right? So next slide. And we want to show you that this is an important chart, right? Everyone looks at the sizing chart and decide what valve we're going to put in. So you remember the area is 453. Perimeter is 77. So if you look at the sizing chart, you would say that, yes, this would be a 26 valve because it's well within that sizing. But you can see if you calculate, it's on 15% oversized. Now, you can see a very lot of calcium on the aortic valve, and you can see on echo and CT. So we've published before that you could theoretically go for a smaller valve, 23, and overexpand because it's only minus 10%, and because the leaflets are very calcified, you're not going to have a valve migration or embolization. So the question is, if you use a balloon expander valve, would you do a 26 and maybe take some volume out with the understanding you might be underexpanded, which we've seen can predispose to halt, or you overexpand at 23 but may run the risk of perivalvular leak. And you will show you the aortogram in a moment, and you can see that it's quite a big root. So most likely, even if we were to choose this, we'll probably go for 26 minus, just to reduce the risk of PVL. However, if you look at the self-expanding valve, supra-annular self-expanding valve, the Evolut, you can see it's right at the sweet spot in the middle of the sizing range. So obviously, with a self-expanding valve, you have to oversize. You cannot undersize or risk of migration, so you have to oversize. And the question is, if you oversize more, you run the risk of pacemaker. If you oversize less, you run the risk of perivalvular leak. So 77 millimeter in our mind here, you can see, is pretty much a sweet spot of where Evolut would sit for 29 millimeter supra-annular self-expanding valve. So next slide. So access, Peristrom can comment?
Sure.
Yeah.
The access-wise, there is mild calcium in both the common femoral arteries, especially at the mid portion. We chose right as the main access because the tortuosity on the right side seemed to be more favorable than the severe tortuosity on the left side. And we also used a bailout up and over wire going from the left common femoral artery in case if you have any issues with proglides. But otherwise, it was pretty straightforward. And the lumen diameters were good enough for the delivery of the big sheath, and we had no issues.
Yeah. Okay, so next slide we have here. So in summary, we'll show you some fluoroscopic images in a moment. 84-year-old. Certainly, we would consider intermediate surgical risk, not high surgical risk. You can see there were not a lot of comorbidities. STS score was relatively low, around 2%. So the question is, the operator preference on the valve choice. Here, in our case, we prefer a supra-annular self-expanding valve because we feel that it's optimally sized. You avoid potential underexpansion. Versus you can put potentially a larger balloon expandable valve, but run the risk of under expansion. So that's kind of the discussion here. So let's show some angio, Dr.
Before
Kini.
that, my thing is this patient with 3-vessel CAD,
Yes.
all vessel PCI has been done, and then we are going to a self-expanding valve.
Yeah, so that's a very good point. So obviously, coronary access is a concern even for intermediate octogenarian, and patient had pre-vessel PCI. So most operators will say, well, I just want to put a balloon expandable valve and preserve coronary access. And as you know, the Evolut FX+ now, that's available in the United States. I think it's just launched recently in some parts of the world as well with CE mark. That, you have now the larger cells, so as long as you have good commissural alignment, coronary access should be fine. Now, the other thing that we always looked at is the aortic root anatomy. If the aortic root anatomy is large, coronary access, irrespective of either valve choice, should be relatively straightforward, okay? The issue is going to be if the root may be a little smaller, the STJ a little bit tighter, so that could potentially make the catheter selective engagement a little more challenging with certain valve. And you can see that here we're now doing the coronary angiogram to confirm the previous PCI in the angiographic assessment. Dr. Kini, you want to comment on the left shot? Any concern from your end?
Angiograph, recent PCI, everything looks okay. RCA will just show you. But going back to the valve choice,
yeah,
I would have, if you had asked me, I would have gone for a S326. Go. Do you have anybody on the Pedro? Any questions?
No questions so far, but I will appreciate if you expand in the concept you just said.
Oh, no, only because of, let me show you the, go back to, look at this. This was a heavily calcified RCA requiring a rota multiple stent. And then we just did the left side. You saw it.
Yeah, this is it.
Yeah, no, look at this.
Yeah, very
There's
good.
a circumflex stent, LAD stent.
3 vessel, yeah.
Yeah.
Rota?
And all this is done. My question is, he's a robust patient, despite being 84, that if he comes back with restenosis, we will have issues with coronary reaccess. Yeah.
Yeah, let's show the aortic root angiogram for a minute in terms of what it looks like, just to show the audience.
Okay, go back here.
There you go. So this is a free cut. So you can see the root is very big. So, I agree with you that, in terms of ballooning spread will be easier in terms of potentially because it's shorter valve, but you can see the root is so big that I think even for tall valve, the access should not be an issue in this case, I think. So that's why, I agree with you, smaller root will be potentially more challenging. And you can see that again, in terms of ballooning spread out of Dr. Kinney's point, that this root is big. So if the root is smaller, we might choose a 23 plus, because you don't want rupture. But I think in this case, we want to seal properly, and that we know that ballooning spread have recoil, with some cases that come back with PBL after like a year or two. So I think a 26 minus will probably be the alternative choice here in terms of balloon expandable platform. So so we always look at the root aortogram to finalize our decision sometimes, even though we have the CT analysis. Remember, sometimes also CT is inaccurate, meaning that if there's motion artifact, the contrast is inadequate. So you have to also look at the angiogram, aortogram to confirm that.
Parasuram, what is your take?
If this patient was a little younger, although he is an 84 and robust patient, but he has extensive CAD, if he was a little younger, my preference would have been a balloon expandable valve. And also, like Gilbert mentioned, the sinuses are roomy, and the coronary heights and the STJs are actually favorable for re-engagement. So if I'm doing a self-expanding valve, which probably would be the option for this patient in my preference, I'll make sure we'll do everything to get the commercial alignment. Because we know that even if we do a 26 and we take the volume off, from our prior publications, where we have done like either undersized or oversized with adding volume, it never actually comes up with the true what is expected for the frame expansion volume. And it's much applicable for smaller size with 23 and 26. We have seen expansion almost getting to nominal in 29, but in 23 and 26, it's always smaller than what you expect. So then if we end up with some PVL or any issues, then it might actually haunt him more. So I would probably choose here just because he's 84. If he was on the lower, if he was a little bit more younger and chance of more degenerative CAD happening, then probably go with the balloon expandable valve.
Now with 26 and with the 1 or 2 less cc's, don't you think you'll get a better sealing?
No, you will. That's what I mean. I agree with you. 26 balloon expandable valve will be the right choice, but nominal will be a little bit risky because all this calcium in the base.
I'm saying.
So you would take a little bit volume out, but then the concern will be under expansion and halt and other things that we might have seen before. So again, it's no perfect solution. So that's why we picked this case for discussion, and this is a very good discussion. Dr. Sharma, just join and you can chime in as well.
No, I think I just hearing everyone say sorry for a little delay, but yeah, those are the very, very great point. Always question comes, and I always remind it that our teaching have been your complex CAD, you have severe aortic stenosis, and at least if there is a good favorable anatomy, a lot of people will go for surgical valve replacement and bypass surgery. But at the same time, we have one randomized trial showing that comparative of that CT surgery, if you do a TAVR and PCI, is also equally good or maybe better. although that trial was flawed in my opinion, having an 11% mortality, which has never happened with the, but in that trial did happen, that was a big difference. But yes, appropriate cases and this sizing. I think what we are learning more and more is do maybe overinflate but undersize, right? I mean, that's what is happening.
That would be ideal, but this case the root is very big, so we would pick the larger valve and expand a bit so that to avoid rupture. And you can always do the double tap what we do already, but this case is more about decision making, like you said. 80 octogenarian, coronary disease, severe aortic stenosis. How do you manage in terms of these kinds of patients, not just in terms of revascularization and aortic valve intervention, but also sizing and appropriate anatomy? Because nowadays TAVR is so common, and now we talked about asymptomatic severe AS. We need to make sure we do the patient a favor by picking the right prosthesis for the patient in terms of lifetime management and durability.
So we have an excellent question from the audience. Dr. Jai is asking, in the case of complex CAD and severe AS, which do you fix first, the coronaries or the valve?
That's a very good point. I mean, actually what has been done in the trials, because they're done outside, compared to America. In United States, if you do both at the same time is a trouble. So now question is what you do first. And you know the Notion 3 and the trial with this the TCW trial, there half of the PCIs were done with the tower. So this is where the issue comes down. But our teaching basically has been that particularly if you're talking a self-expanding valve, we do the PCI after, because many times we find out only after the angiogram. And that is what the trial, the complete tower is. Complete tower is successful balloon expandable, followed by PCI post. Now, I think what makes sense is that if you can simple lesion, you can do tower and PCI at the same time, as long as you have enough or appropriate financial reimbursement by the insurers. So that's one of the issue. Second, people worry about having a bleeding complication if you do PCI and tower. I think more of them have come up and showed studies that now with the current day and age, that you just give maybe IV cannula during the procedure and using a clopidogrel, that it does not increase the vascular bleeding at present. And of course we are using a closure devices, very meticulous vascular technique, so that's less of an issue. I think more, in my opinion, is the practice pattern and the reimbursement pattern, because you can use multiple stents, multiple devices, and then you do a tower and the reimbursement is not appropriate. Then what will happen? It will be a financial penalty to the institution. So therefore, just coming back to the point, Pedro, I think our policy has been now that do the tower first and then do the PCI later. Whether it's right or wrong, I mean, there are many studies have done and which favor this approach. The examination and few trials have shown that this approach of the PCI after tower is probably the best one, although there is no randomized comparison that way. Yeah.
Just to finish on this question, let's assume left main and 3 vessel. Would you do the TAVR first, or would you do complex PCI with BAV?
Yeah, so if we know the CAD before extensive CAD, our goal has been do the BAV, do the PCI, and then bring patient 6 to 8 weeks later for tower. In this case, we did not do the BAV. Actually, this case was done outside. So they did a PCI and referred the patient for the tower here. But many of those cases, we do both combined. Do the BAV if the gradient is high. We are talking about the velocity more than 4.5 or so. If it's less than 4, I think you can just do the PCI. But if more than 4, 4.2, 4.5, then you do BAV with the PCI and then defer your tower for about 6 to 8 weeks. Because I can tell you, one of the patients I lost about 4 years ago, because we had a bad peripheral disease, we did the PCI from the radial, also left main, and patient had a high gradient, we did not do a BAV, and patient 2 weeks later came with a severe heart failure and did not make it. So that's the case I always remember in my mind. If you have severe AS and CAD, if you can do a BAV, because sometimes you have to wait not only 4 weeks, sometimes 6 weeks, 8 weeks for various other regions, something found on the CAT scan, some other vascular issues happen. patients compliant, non-compliant. So many factors with a high gradient, doing a BAV which is quite safe, and you are under a small balloon. Don't have to be a full, but just decrease the gradient by 30-40%, so the patient remains good for next 4 to 8 weeks.
Great. We have an activated audience today. So TAVR in the young, long-term durability, any data?
Well, I mean, those are all the ongoing various trials to answer that question. But I think younger the patient, little less durability is there. But still, whether you do surgery or TAVR, we learned that as far as the valve degeneration, valve durability, the data are identical. Now, with the SAPIEN, with the Ultra Resilia, for the surgical, very good literature, very little degeneration up to 8 years. Whether it will translate with other kind of surgical valve as well as the TAVR valve need to be seen. But by and large, we have learned the both TAVR and SAVR, both the valve degeneration or valve longevity is identical in those compared cases. Any comments?
Yeah, I think, keep in mind the trials only randomized average age around in the mid-70s, right? 74, 75 years old. So we don't really have good data on a patient less than 65, certainly, and definitely even 65 to 70. We're very few in the trial. So again, remember, in the real life, you also don't exclude any anatomy. Those trials excluded certain anatomies, especially for the partner 3. So again, the trial data may not necessarily translate to real life. That's why we always tell the patient, you're young, you're getting a TAVR or SAVR for that matter, you need to see your cardiologist every year to have an echo. That's like an annual checkup. That's how we recommend it, just like you do an annual health checkup. So that's very important to tell the patient. And the second point that we tell the patient is endocarditis prophylaxis. Yep. So if you have endocarditis, it's a big problem for any prosthesis. So we ask them when you go to the dentist, make sure you take antibiotic prophylaxis and have your dentist give you a couple of amoxicillin or clindamycin so that you prevent any infection risk.
And for the same token, all the studies have shown low risk, intermediate, high, that endocarditis incidence is similar between surgery and, okay, again, these are the randomized patients, surgery and TAVR. All right, Anu, tell us where are we now? Show the hemodynamics, please.
Now we cross the valve.
Yeah.
We try here to show you AR2 and you see the opening right there. Oh. Good.
Good.
So that's done, and this is the gradient we have at the pigtail.
Yep.
Okay.
We have that. Good. Let's start.
Okay.
Yeah, and there's also moderate aortic insufficiency as well, because that's known for the baseline. It's
we are going to do a BAV also.
Yeah, a small one, not an aggressive one because of the AR.
Yeah. And we did the live echo, right?
Yes.
Yeah,
we
and,
showed it.
And Stan already showed the moderate AR on the echo beautifully on the long axis. So these are the cases that you don't want to be too aggressive. You don't want just enough so they can cross the valve easily and so that the self-expanding valve will work to avoid under-expansion. Because remember, after the valve is deployed, you have to remove the nose cone. You have to remove the system. So you want to make sure you have enough room for that, because a lot of people now talk about minimalist TAVR, in and out. I think now we know that someone asked earlier, young patient, TAVR, durability. We know that under-expansion is a bad thing for TAVR. As you saw in the accurate IDE trial, right? It increases heart endpoints such as stroke, and now the device is completely removed from the market. So we know that commercial TAVR devices need to be sure, because unlike surgery, surgical valve are in a rigid frame, right? It's not a flexible stent. TAVR is on a flex like coronaries, right? So we now routinely post-dilate if we think that the patient needs it for durability reason. Just like in coronary, I'm sure Dr. Sharma will tell you that, after your PCR, you will not just leave it alone. You will definitely post-dilate to make sure it's optimally expanded. And now there's imaging studies, right, OCT and others, to confirm that. So we don't have OCT, obviously, or IVUS to talk about TAVR valve.
150.
But certainly it's important because we see that on CT scan. So.
And I think more and more data will come that the TAVR recoil is a true phenomenon.
Yes.
And we have seen few cases, perfectly working valve, deployed at time 0, and after a few months, there is
Back
a
up.
recoil and there is a clear-cut high gradient and some PVL. We go back and say, you know, what did we do wrong? And we looked into it. Every aspect we did correct. The sizing, dilatation. Now, of course, the second tap where the post-dilatation, I mean, 2 times will decrease that incidence need to be seen. But the TAVR valve recoil is a true phenomena. I know it has not been talked much, but that is what we have seen in the real life.
Do you believe the post-dilation can cause degeneration earlier?
That we don't know. No one has an idea, but it does improve the expansion. And we have a paper presenting at a New York Valve coming up in a few weeks talking about this fluoroscopically, and we are in the process submitting it for publication. So
I believe in that.
Yeah. That it'll cause
because surgical valve nobody will touch. Remember how they do it, right? They remove it, they place it, and the valve is opening. There's no post-dilatation.
Yeah. Correct. Yeah,
Here,
there's no such thing.
We often post-dilate.
But remember, so far, if at all, compared to surgery in those randomized trials,
Right.
our valve has performed better
That's right.
than the surgical valve in terms of valve degeneration, residual gradient, residual and the follow-up effective aortic orifice. So until we have the data of 10 years from the Notion 1, many data 5 years for both partner and Evolut low risk. So far it does not happen now. Nobody has really correlated that whether post-dilatation did any much difference. I think we need to, this field is evolving and we are learning more and more. And we'll be probably understanding.
Yeah, I think those are older patients as well. So the younger ones is the biggest, unknown, right? I think, Dr. Sharma?
Yeah, that
in
is
terms
correct.
of whether they because we know even for tissue valve in younger patients in surgery, they don't last as long.
That's
so,
Okay.
150.
Inject. You think your
No, I'm okay.
C-tab is good,
No,
right?
good. Okay, 100, please. Yep. Okay, let's see, maybe a little deeper. Let's take a look.
Inject.
Actually,
I
not
think you're
bad.
good.
That's good. So this is very important for the audience. So the contrast is only the sinus space. There's calcium at the base. That was why we talked about earlier. So it's actually shallower than you think. Let's take a breath and show that again. So you can see it's around 4 and 6. Yeah. It's a big root, so you have to be really
fill
careful.
up with the dye and then stop. Yeah, right there. Yeah.
And then the other important thing that Dr. Sharma has taught us is that if you want to post-dilate, you have to not implant too high.
Yeah.
And then Dr. Kinney also mentioned that before. It's very important to tell the audience. Dr. Kinney, you want to mention that to the people that if you implant too high, you have your D sign. Then you cannot post-dilate, right?
And then you get the D sign, then absolutely no, you're not able to
150.
post-dilate.
150.
Because we know we're going to post-dilate on this one for optimization. Good.
Okay, ready?
Good. Okay, 120.
120.
And paying attention to this commissioner alignment, particularly this patient who is may come back with the restenosis. The PCR was done last few months.
Yeah.
Very important.
Where's your, can you see the diamond?
Yeah, so we will show that to you right now. Let's look at the coplanar view.
If the audience is interested, we will be doing a case on Friday, our CCC symposium, where there is not a good commissioner alignment, but patient has a left main disease.
Okay, back up. Okay, so this is the coplanar view pretty much. We can look at the
after evaluation.
Okay, so you can see the C-tab with the inner curve, which should be all right. And if you want to go back to the cup overlap view, which is RAO2, so you can see the cells here. So you can see it's underexpanded. So I think we need to expand this first to be able to see it better.
I'm looking for the diamond.
Yeah, no, I know, but we need to just look at this. The waist is scrunched up.
Yeah.
Post dilatation with what?
Oh,
What's the balloon size?
24 true.
Yeah.
Opening a 24 true.
Yeah.
So I think there is no need to do hemodynamics. We saw the unexpanded valve frame. We are going to dilate and then do the hemodynamics. Yeah. And as you know that all that trial data with the combining for the cerebral embolic protection, the whole enthusiasm of the CEP has gone down. And our number also has gone down. At one point, peak time, we used to be 58. After a few months ago, we became like in 25. I don't think we are 25 now, even much lower.
10% maybe.
Maybe 10%.
Not even 10.
We haven't done any consecutive.
We're done in a while. And the country-wise, the last report of the fourth quarter of last year was 16% in the TVT registry. But I'm sure that number is way lower now because of the two major trials showing.
Okay, 180.
benefit, yeah.
180.
So look at the
Clear
difference.
expansion, yeah.
Then you can see
Okay,
the
now
diamond
you can see the diamond.
Yeah.
Okay, good. Okay.
Okay, keep pacing, keep pacing.
Okay,
Back up.
Good. Pigtail.
Get a picture.
Back out, back out. So you see so for the audience, the only way to see under expansion for self-expanding valve is in the kind of cuts overlap view, aerial caudal view. If you see on earlier when we did the aortogram, you did not see that because you're on the kind of en face or free cuts view because anatomically is in the long axis of the annulus. This is in the short axis annulus. So that's how you can see, look at before and after.
Yeah. See this one? And now.
Look at that. You can actually see the diamonds overlay more aligned, what I call the frame alignment. So you saw the initial aortogram do not really have PVL, but this is for frame expansion, and we now know from several papers that it is a precursor for halt and valve failure and even mortality. So in patients, we respective, because we don't know if this patient will live to 95 years old. That's 15 years from now. So we need to make sure the patient, the valve will last. Forget about the CAD in terms of progression. Because,
Okay, zero,
actually,
everything.
there's a recent paper showing that the CAD progression actually is quite low. After aortic valve stenosis, it's more the valve durability that's the concern. So.
We have another question about the embolic protection device.
Yep.
So let's just comment on this for this case.
Yeah. Now, the question comes, the two major trials, the BHF Protect and Protected TAVR, both showed that no benefit in overall stroke, but there was little signal in the disabling stroke. So that's the only one remains. So the question comes, is it worth the try to decrease that and of course go through all the hassle, the timing, but if really
Zero.
effective, then we do. But when it's a borderline, people have gone away from it. But the field has not ended yet. There are 3 active trials ongoing at present for cerebral protection, and we are one of them, Protembo, which is from the left radial. There are a trial from the groin with the 8 French guide catheter. There are many, 3 of them, as I mentioned. Okay, now look at the gradient, 0. So looks good. I don't think we need to do aortogram because that was already done before.
We can look at echo now. Let's look STEM and
Okay,
Hafiz. Let's look
all
at
right,
the
echo team. So that's the key. So now maybe Parashram can say which case we are using now the cerebral embolic protection.
Sure, Dr. Sharma. We have definitely gone down on our use.
So let's say in last 2 months since the trial data have come,
Sure.
which case you will think we should be using it now?
We tend to use for valve-in-valve, especially degenerative transcatheter valve or surgical valves, or bicuspid patients, especially low risk, or anyone with actually heavy calcium score, like high calcium score. Those are the patients that we restricted to use for cerebral embolic protection device.
Okay.
What about TAVR in TAVR?
No, that's the same.
valve in
TAVR,
yeah.
the valve degeneration, percutaneous versus,
but-
TAVR versus surgical. Second is the patient with the bicuspid aortic valve with a high calcium score. Other question
wire-
could be
the
the
wire
patient
is still
had
there?
a CVA before.
The wire is out?
Recent
Yeah.
prior strokes.
The wire is
Prior
out.
stroke.
Yeah.
With some PVL.
What is happening now? Show us, tell us.
Yeah. You go to Parastana. Yeah.
Yeah, the diastolic pressure didn't change at all
Yeah.
after the TAVR.
Right. And we
But
saw that there was
Stanley's-
no gradient. Yeah.
So it's some PVL as you see.
There's some PVL?
Yeah.
Yeah, more.
Wow.
Yeah, it's more
Okay,
than
good.
mild. It's mostly
Correct.
moderate PVL.
No, there's no
Moderate
PVL.
You're saying moderate PVL.
That could be that calcium nodule on the right side.
The wire is out.
So tax.
Yeah. Let's do an aortogram and see.
Yeah, let's do the aortogram. Because otherwise you had to go with a 25.
CMAT, yeah.
Yeah. The moderate, the mild is okay. but you cannot come out of the cath lab at this time more than mild. That we learned. Mild is still all right. I mean, of course, ideally it should be 0 or minimal, but mild is still okay. But that more than mild, we should do everything possible in the lab, unless somebody is 90 plus years age and has a limited lifespan. But somebody even 80, 82, because going to live,
Why is the CR
may
so
live
bad?
10 plus years, so that you
Why is
have
the
to
quality
come out
so
with
bad?
the mild. You need a wire or you're okay?
No. I'm just doing urogram first, and then we can recross.
No, yeah, good. A little further in. Yeah, good. Yeah.
Okay, so this is no parallax now.
Yeah.
So let's see.
Oh,
Yeah, that's definitely PVL. Okay.
Yeah.
All right. Good.
All right, let's get the wire. Let's come.
You
25
think
Siemens.
you think
Yeah.
it's deep? Go back.
It's a little on the deeper side, but it's still acceptable.
I mean, the skirt is below.
No,
Is it? No.
Yes, okay.
no, it's around 6 millimeter. There's a lot of calcium up top. I think it's just the expansion issue.
This is Safari. Cross it. Scale level.
So which balloon would you choose now for the post-dilation?
Good question, Dr. Moreno. So 24 is non-compliance kind of the upper limit. So once you have that, you have to go with a semi-compliant balloon. So for per the IFU. So you'll need to now do a 25 semi-compliant balloon.
Now we have the new balloon nowadays instead of
ZMed.
ZMed. Right? There is a new balloon. 25. What's the name? We actually evaluating another balloon. We have that.
Yeah. That's for a native BAV, right? Not for the.
I see. Not for the
Yeah.
tower wall. Okay.
While we do this, SS, there's another question. We're talking here about
Sure.
TAVR for isolated AI.
Yeah, so there are no FDA-approved devices right now. There have been lots of literature showing that, off-label use of commercial devices have been done, and the device have a higher risk of migration and
think it is straight
embolization, even with the contemporary devices. So, so it's definitely off-label. In high surgical risk patient, you can consider, but it depends on the anatomy of sizing. So, in patients with ASAI,
This is not.
you can treat, just like in this case. But if it's pure AI, then the sizing becomes an issue. So remember, all these sizing charts that you see that we saw earlier are for AS, not AI. So you need to be very careful about AI patients that if you use a balloon expandable valve, you have to oversize more because you don't want migration. But you run the risk of aortic root injury or root rupture, okay? With self-expanding valve, we don't know whether you need to oversize more, but because of AR, typically the LVOT outflow tract is bigger. So the valve like Evolut or Navitor, other valves, when they deploy and release, because there's no support from the LVOT, it may release deeper and in terms of more ventricular. Then you have a problem of fixing maybe AR, but then you have PVL. So in those cases, people have actually gone to use a second valve, so like a TAV in TAV, with a balloon expandable valve to pin the tall self-expanding valve against the anatomy.
Yeah.
So there's a very unpredictable still. And so I think it's very important to know that these are the limitations of commercial technology. Now, there are two technologies that are in the trial that Edwards are now purchased. One is the J valve, one is the Yana valve. Yana valve has been presented recently in ACC and also
180.
published in Lancet.
It's not connected.
But
Where is the?
off.
Wait.
Off,
We
Pacer.
don't have a blood pressure.
So
Change to
what we need to
change the transducer.
understand is that there are still limitations in with pure treatment
Can you
of
change?
pure AR.
Okay, good, fine.
Got it.
Yeah. So another question people have done, which actually the very innovative from the Cleveland Clinic, that what if you with a cautery make a hole into the leaflet and then deploy these valves commercially available. So
180.
So rather than putting in the center, you're going through the leaflet so they don't move. Okay, going up.
Simultaneously, we have another question.
Valve is, balloon.
Need it further down?
Yeah.
Okay. Let's recover. Off.
Okay,
Yeah,
now.
leave it there. 1 second, let it recover
No,
from me.
it could be the balloon is too big also. That's why I moved up.
Yeah, no, we'll do it again. Okay, go
Okay.
again, quick.
Hold it.
Yeah.
Okay.
Yeah, good. It's coming up. Good. Okay. Off.
Off.
Okay. Echo.
Okay, come back. Wire out.
Right out.
Yeah, Dr. El Reyes is asking, what about if
Pull back, pull
after
back.
post-dilation the AI is still there, the paravalvular leak? What
Good
what would be
question.
the next step? Yeah,
Good question. So in that case, we might have to put
another
typically
valve,
a balloon expandable valve inside for the radial force.
huh? Okay.
So because we've known that, plugging the PVL is very challenging, especially for 12 valve. So most people have shy away from that now. So if the anatomy is suitable, we would wait, 30 days to evaluate, because as you know, for the Evolut platform, the PVL does improve with time at discharge, and also 30 days, and you can see all the trials, even the recent Evolut low risk trial, the PVL has significantly reduced with time. So we tend to not do anything, especially given the patient has moderate AR to start with.
Yep.
So now the diastolic pressure looks a little bit better.
26,
So the most important physiology here is the AS. So now there's no AS, and the gradient, you can see there was no gradient across the prosthetic valve. We would tend to revisit the issue at 30 days. Because remember, anytime you do something, there's always a price to pay. So you don't definitely want to do this until you're sure that the patient is symptomatic and actually physiologically need an intervention. We don't just treat a color or treat a number, you treat the patient.
Okay, but so you see some improvement, right?
Yep. The diastolic pressure went up.
Yep. And as long as it become, 1 plus or less, we are okay.
Also, we have another question. What about fixing the paravalvular leak with any device?
Yeah, that's what.
That's what we
what
just
he
talked
just
about. So
mentioned. Yeah.
So the plugging is very difficult in the aortic position, because especially for a tall valve. And also remember, it's not like a discrete hole. Like in, for example, mechanical valve, you have a prosthesis, you have a round hole,
Good.
you have a native anatomy that's round, right?
Yeah.
TAVR, you have a native anatomy that has now the calcified leaflets. You don't know where the gap is, where the hole is. So it's very hard to go on a fishing expedition to find that real hole. So it's very different from, let's say, plugging a mitral valve or a prosthetic valve. It's a totally different kind of technique. So what we need to do is to basically look and wait, and the only way, and we've done this in other cases as well, whether it's tall valve, short valve, doesn't matter, to actually, you have to post-dilate,
Yep.
and then if it's necessary, to put a second valve in there to increase the radial force. So that's how we would manage these patients. But we don't do it acutely unless, there's a hemodynamic concern or there's a stability concern, meaning that the valve is not stable at its current configuration.
Absolutely, and the question always comes, somebody who has a CAD and you put these plugs, they actually interfere in the subsequent engagement. Big trouble. I actually have 2 patients came from outside over the years, and was so difficult to engage left system because they put the plug, a paravalvular leak closure.
Yeah,
But
and
anyway,
following on these issues of paravalvular leak, let's assume it didn't work. Question is, what is the size of the balloon expanding valve that you will put in?
We already decided that 23.6, and that's
Same
what I think. Going back to the question we've started, we should have.
So that's a great question. So basically, you here, because the mechanism of the PVL, not stenosis, you would do a CT scan to look at the sizing, but you would tend to upsize to a 26 here for the second valve for PVL, not for stenosis or prosthetic regurgitation. If it's pure prosthetic AR or AS, like let's say this valve 5 years from now, 10 years from now, had failure because of stenosis or regurgitation, we would do in vivo sizing by CT. And we'll more likely use probably the 23 plus volume, because we've seen that if you oversize, you might actually have a risk of migration because of the mismatch. Because remember, the waist of the 29 Evolut is 23.
Yep.
Yeah, it's not 26. So you just have to be very careful about your inflation when you do your second valve, if you use a short valve in a tall valve.
Also, these patients
AI to begin with. Beautiful. Yeah, good point. All right. So with that note, we have completed our procedure. Now, Parashram is closing the vascular access now, and we can go our presentation for next 10-15 minutes. So up to date, we have shown the 29mm Evolut post-dilated with a 24 and then 25mm balloon, and hemodynamics are better. It still remain, I would say, 1+ PVL, but hopefully this patient will tolerate better. So EuroPCR is becoming a big event nowadays, and there were a lot of trials were presented, and same, just like the ACC, there were more structural heart disease trials were presented, structural heart intervention compared to the coronary. Same thing in the EuroPCR. There are like 10 structural trials presented and 6 or 7 coronaries. So this is what I'm going to talk about. We have Evolut, which we showed a few months ago also. 5-year outcome of the low risk TAVR. Now it has been published in the JACC. As you can see here, patients are followed and basically showed the identical outcome of 5 years. You can see wall endocarditis, wall thrombosis, all good. Negative, AFib, higher in the surgery, pacemaker, higher in the TAVR. Otherwise, exactly identical outcomes as shown here. These are the individual endpoints. And now, another good thing, and this is a question which you asked earlier, the valve performance. You look at the valve performance, actually the hemodynamically, the valve area was 2.1 at 5 years compared to 1.9 with surgery. Very simple. Why? Because 29mm was the valve in the TAVR group, and it was 2.1, 2.3, or sorry, 23mm valve in the surgery. So clearly, all the trials have shown that on a long term, you have a less residual gradient with the TAVR compared to surgery up to 5, 8, 10 years in the notion, and same thing in the Evolut 5 years and compared to surgery. But identical outcome which I showed you on the previous slide. The key is only another negative is the mild, more than mild paravalvular leak. 15% in the TAVR group, surgery is almost, we know there is no leak at all. So that now, will it show any difference at 8 or 10 years? We need to see. Now KCCQ summary score all do great. Clearly we know surgery will take a little time for patient to recover from the surgical incisions, but otherwise excellent recovery of the our overall patient's well-being. So then the Evolut low risk trial, we have 3 trials now, Partner 3 and Evolut 5-year data. Then we have Notion up to 10-year data and showed all no difference in surgery or any individual endpoint or valve degeneration between them. Now second, very interesting, which we have been waiting for. We know that FFR has become the usual, our strategy in evaluating coronary artery disease before doing the stenting. And many trials, FAME 2, FAME 3, all have shown that FFR guided PCI is better than angio guided PCI because it decreases the overall stent usage without creating any harm. So what about in the AS patient? FFR was, people used to think about do the IFR, so you don't give adenosine. And there have been a lot of data when this trial was being planned, the called FI TAVI. That time there were discussion about both FFR and IFR. But later on, after some experiment and so, the investigators decided that we're going with the FFR only. And so this basically was a trial to see whether you do angio versus FFR guided with the during PCI, patient who has severe aortic stenosis. And you see here, FFR guided was if more than less than 0.8, but if it was more than 0.85, it was left alone. But if it was 0.81 to 0.84, they did after TAVI another FFR, and if it become less than 0.8, then they did the PCI. So FFR guided PCI versus angio guided PCI, and of course seen the outcome at 1 year. As you can see, this is again done outside. Look at the 60% plus PCI was done during the TAVR timing, which we don't do, but that's the way the data are. And of course, the need for PCI in the angiographic guided is a 91% with FFR guided 60%. Similar to our FAME 2 trial, FAME 1 actually, the 1/3 decrease in FFR guided PCI. So that was 63% compared to 98% in FAME 1, and here is 91 versus 60%. Clearly, FFR makes you to put less stent despite the significant lesion. All these were the SAPIEN valves, general anesthesia very small. And what were the findings? To our surprise, mortality difference almost double, 8.5 in the FFR guided versus 16% in the angio guided. So this is an individual endpoints on the right side. No difference in major bleeding, as I mentioned. You can see here acute kidney failure, periprosthetic MI, all those things for vascular complications were similar. But very interesting is that FFR guidance gave rise to a difference in mortality, which they had never done in coronaries. Coronary FFR guided, the benefit usually occur by decreased revascularization, some cases little MI. When you pull them, then comes little mortality benefit. But here, single trial showing the half 50% decrease in mortality with FFR guidance. Now this is, we talked about protected TAVR and BHF protected TAVI trial. This basically shown combining in the meta-analysis. These are the individual trials which overall were negative, and they combine now TAVI without cerebral embolic protection and with cerebral embolic protection, 5,000 plus patients. I mean, large number of patients. And so these are the overall distribution. Low syntax score, coronary artery disease was present in about 41% of cases. And basically benefit is all stroke identical. In 10,000 patients, if you have difference of 0.1, it's normal. Even disabling stroke was 0.3 only. So 1.3 to 1, as with the, and say more important is that if you have per protocol, exactly the way it should be done, per protocol versus intention to treat, and this is where we saw the difference. All stroke on the left side, disabling stroke on the right side, even in the all stroke per protocol, see the p-value become 0.09 kind of trend. But if you have per protocol disabling stroke, absolutely positive in adjusted and unadjusted group. So clearly it seems to be that once you do correctly as protocol, timely, your technique wise good, and analyze the patients who got the CEP, there was a benefit, clear-cut benefit in reducing the per protocol disabling stroke. So that basically is. Now, this is the valve, the my valve landmark trial initially presented 6 months, now they presented 1 year data comparing. The landmark trial was comparing the my valve with the commercially available valves, which is the SAPIEN or the Evolut. The 6-month data were presented before in the Lancet, and now Patrick Soraya actually presented in EuroPCR up to 1 year. Exactly identical, no difference. No difference in stroke, no difference in mortality, valve-related hospitalization, exactly identical. Little different than what I suggested last week. Last month, compare TAVI. Compare TAVI trial, another multi-centers in Europe and Germany, and so SAPIEN compared with the my valve. There were some differences, and most differences we saw, there were more moderate to severe aortic regurgitation with the my valve, and the need for pacemaker was higher. So this is basically, and of course, the only difference was patient prosthetic mismatch was much higher with the SAPIEN valve. But overall, just to say, compared to the landmark trial, compared to TAVI 1 year data, are slightly different, but overall, you go to the main endpoint, death and stroke, identical. And this is the valve, hopefully will come soon to the United States, which will cut down the cost of this valve. So that's what it has been so popular in India and Europe, actually many places. They have deployed 44,000 valves globally, 44,000. I thought it will be about 30, but I called them today, confirmed it, 44,000 my valve have been deployed globally at present. Then question comes in the bicuspid aortic stenosis. We know that a lot of data are the selected cases, because our partner trial, Evolut trial, have a registry of the bicuspid cases. So where we did. So basically bicuspid versus tricuspid in a selected cases have been a similar outcome in STS TBT registry. And we know the outcome of the bicuspid is dependent on what type of the bicuspid morphology is there, whether no calcium, calcium with raphe, or leaflet calcium, or both. And clearly we have the calcification of both, your event rate goes almost like 4 or 5 times. So clear importance of the bicuspid valve anatomy in terms of the outcome. So once you have the calcified raphe as well as excessive leaflet calcification, those patients have large trouble and should not, they are associated with the high event rate of PVL, annular rupture, and then issue with the coronary access and the structural valve degeneration. All those are more troublesome with these cases. Now, we also remember the Notion 2 trial. A Notion 2 trial where the patient with a younger age, not younger, but still more than 65, they have all comers, the tricuspid versus bicuspid. In the bicuspid cohort, which was 1/3 of those, 18-20% of cases, in tricuspid there was no difference in the outcome of the surgery versus TAVR valve, but in patients who have the bicuspid, event rate was tremendous, 3 times death and disabling stroke, and overall event rate was 3.9% in the SAVR and 14.3% in the TAVI group. So clearly saying that bicuspid is not for TAVR yet for the current devices. And they presented this recent registry called TriNext Global Network Analysis of the bicuspid cases. Large number of patients, but then they have the matched population of 1,200 patients, surgery versus TAVR. The message came out about the same, what we said, that tricuspid valve, the bicuspid valve, TAVI, had a much higher event rate of death, MI, stroke, heart failure, and death. It is almost double, and 2.5 odd ratio. So clearly, it's a bad. Seems to be the TAVR is not for prime time for the bicuspid aortic stenosis because high death rate and heart failure and so. So with that note, so question comes: what do we do with this bicuspid aortic valve? I think we understand selected cases can be done, but to me, you need to answer that question by a randomized trial with a TAVR versus surgery in appropriate bicuspid patient, not with the calcification of both the raphe and the annulus. Those cases will fail anyway, may be harmful. So otherwise, SAVR 0-1 may be randomized to surgery versus TAVR. Gilbert, any comment on this?
Yeah, I think the issue with bicuspid is the unpredictability of the raphe. I think in March McCart's paper showed that if you have more calcified raphe, more lethal calcification, you have worse outcomes. So I think for a randomized trial, you have to really say these are not appropriate for randomization, and you'll be very clear. I think there are patients we've treated who are appropriate for it. I think it ultimately comes down to patient selection and then anatomy.
Yeah, he actually, Raj Makkar is taking the initiative. He has sent the review asking people. So should it be an age limit for that? That's another point. Should there be an age limit cutoff? Should be 65, or you can go further lower down as long as there is no significant aortopathy with this bicuspid valve. So I think there's all being planned. Whether it will go down to the final randomized trial need to be seen. So with that note, let me just take you through our take-home message. 5-year data of the Evolut trial showed excellent comparative result with surgery, and we know the class 1 indication. Then first randomized trial of FFR guided versus angio guided has shown that FFR guided PCI is safe. That's the first thing I learned from the trial, that we were so timid, so afraid using adenosine, but they did in the large number of patients. So the FFR is completely fine, and of course it decreased the mortality at 1-year follow-up. Then the meta-analysis of the individual 2 randomized trial data of the CEP device showed no benefit, but per protocol there was some benefit. So I think although some people think it may become class 3 indication, but I don't think it will become, because there is still some benefit, particularly when you did the per protocol for the disabling stroke. So cases which we discussed earlier who have a high incidence of CVA post-TAVR, I think those will continue to be used. That may be 15-20% or less than that. The next extended follow-up of the landmark trial showed both valves are identical, and as I mentioned, have been used in more than 44,000 cases globally and working quite well. We have the good effective balloon expandable valve. And lastly, the TAVR has shown to be a viable option in selected bicuspid AS patient. It performs inferior to surgery, especially in patients with younger age. Notion 2. A dedicated randomized trial comparing TAVR and SAVR in this field is much needed and is being planned at present. So let me take you 3 questions. Following statement is not true about the results of the Evolut low-risk trial comparing TAVR with surgery in symptomatic severe AS at 5-year. Primary endpoint were similar. There were higher valve thrombosis in the TAVR group versus surgery, numerically higher aortic valve area in the TAVR group, and higher pacemaker rate in the TAVR group. And answer clearly is that there was no difference in valve thrombosis between 2 of them. Very compared to the intermediate risk Partner 2 trial did have valve thrombosis issue, but all the trials of the Evolut have no issue with the valve thrombosis so far. Even the intermediate, our CERT TAVI and so. Then, based on the physiological guided 5 TAVI, the true findings comparing accept means which one is wrong. Higher PCI number in the angio versus physiological guided group. Post PCI were done. Most PCIs were done concomitantly during TAVI. Primary outcome of all-cause death was similar between the two arms and numerically higher non-significant stroke rate in angio versus FFR guided. And answer there is C. The primary outcome of the all-cause death was half in the angio in the FFR guided group compared to angio. The last question, following outcomes are true regarding the status of TAVR procedure in the bicuspid AS, except means what is wrong. Similar outcome of the TAVR in selected bicuspid AS versus tricuspid, variable TAVR outcomes in different bicuspid AV anatomy. Notion 2 trial showed differential outcome of TAVI versus surgery in bicuspid versus tricuspid severe AS, and then similar incidence of all-cause death and heart failure at 3 years after TAVR or surgery in a recent match bicuspid AS registry. Answer is wrong is D, because there was a 3 times higher mortality, 2 times higher mortality, 3 times higher death, heart failure, hospitalization in the bicuspid group compared to surgery. With that note, I'll complete my presentation.
Before we move on, SS, there are 2 more questions about PVR. The first one is how to quantify PVR in the case of multiple leaks along the circumference of the TAVR. I don't know if Dr. Lerak is still there.
Lerak is there, yes.
Yes, that's a great question. On the short axis view, you can planimetry the area of each PVL, and there are guidelines. If it's less than 10% is mild, if it's 10 to 30% is moderate, and more than 30% is severe. Compare the areas of the PVL to the frame of the valve. So that's the criteria.
Fantastic answer.
Of course, this can be very difficult, so you have to put all together, and we can measure pressure half time too, so it's many criteria. But the most easy criteria is that short axis view frame of the valve and measuring the perimeter of the PVL.
Fantastic. The second question is a little bit futurist, and is what about if you have a tremendous calcium nodule and it's not going to get better, this PVR, can you use IVL?
Yeah, so I mean, the question is...
IVL, hold on. Which IVL are we going to use then?
Yeah, so, the
peripheral, coronary?
IVL has been used for various, issues, but I don't know whether it's going to work in this. But they are planning actually using a bigger, like they have a bigger cutting balloon now for the aortic valvuloplasty, same the IVL. And even if not, the question, it will not be a bad, particularly peripheral IVR of 6 or 8 millimeter, if you can use it on the one side where there is a calcific nodule. So I would not be, it's a little crazy question, but very provocative and practical question. And we have seen that. Many of these, even when they're doing a TMVR, mitral valvuloplasty using IVL to really fracture that calcium. So it's not far away, but because a lot of things are being planned at present, that what can be done for one, delayed the progression of the aortic stenosis, and secondly, prevent the degeneration of the TAVR valve. So I think all these things will continue to evolve.
Okay, so having said that, let's close this session. Thank you so much for the cath lab. It was an unbelievable case. And remember, this case and many others can be viewed this afternoon at ccclifecases.org. And our life health cases are every month on the second Tuesday at 9 a.m. This next one will be July 8th. See you then. Thank you so much.